pathophysiology of ovaries, largely with regards to the various hormonal mechanisms, how the ovaries develop, what are the various regulatory factors which are there, and how do we have a normal cycle. Hypothalamic pituitary ovarian axis. The most important, of course, is the GnRH, which controls LH, which acts on the theca cell using the LH receptor to produce progesterone as well as androstenedione. This androstenedione is then activated by the granulosa cell aromatase to produce estradiol. And this estradiol will act on the estrogen receptor. We'll talk about ES1 and ES2, which causes development of the breast, the bones, as well as the uterine growth. So this is a typical hypothalamic pituitary ovarian axis. The most important of all of this is, of course, the GnRH. And GnRH is largely secreted by the arcuate nucleus of the hypothalamus, and these neurons are then taken. So this is like the hypothalamic hypophyseal portal system through the stalk where it is taken. Now, as I was talking about germ cells which are produced in the hindgut, and they have to go to the gonads in the area of the urogenital ridge. Similarly, GnRH neurons have to migrate right from the nose. So olfactory plecoid from the neural ectoderm, they have to migrate a lot. And from there, along with the olfactory neuron, they have to migrate. And this process is regulated via multiple genes. So multiple genes regulate a single process. Defect in a single gene may not cause a problem, but 2 or 3 gene defects may cause a problem. What is this type of inheritance known as, Vibha? So this is an oligogenic inheritance. So things which are very vital. So these genes are absolutely vital for the survival of a species. Similarly, eyes. So for eyes also, you have got multiple genes regulating the same thing. It's like a redundant phenomena, like glucose. You've got growth hormone, you've got cortisol, you've got epinephrine, you've got glucagon. If one is defective, the other will take over the picture. Same, if suppose FGF is not working, CHD3, some work will be done by that. So a lot of these genes will be acting there. They will push it through the olfactory plecoid. And from there, you have got the anosmin 1, which acts. So this is the point in which both olfactory neurons and the GnRH neurons come into the picture. So if you have defects at this level, what will be the hallmark clinical presentation which is there?
So if they will have delayed puberty as well as
smell sensation problems. So because all of them are involved in that. So we talk about Kalaman syndrome as an example. Kalaman syndrome is because of anosmin 1. But if you have defects in any of these, CHD7 is Chart syndrome, which will have choanal atresia, hearing abnormality, anorectal malformations. There also you will have the same thing. So you will have a problem of anosmia. So anosmia and hypogonadotropic hypogonadism means a very proximal defect to begin with. No anosmia means the defect is a bit later on from that regards. So from here you have got ProKR2 and then other which will take it through the arcuate nucleus, where your olfactory neuron will go up and go to the olfactory bulb, and you will have the neuron which gets located here. And from there, around 15 weeks, you have got the hypothalamus which is functioning. So first 15 weeks, we don't have this hypothalamus. We don't have this LHFSH. That's why that HCG is very important. In males, HCG is controlling the testosterone production. Otherwise, everybody will become a hypospadia, basically will develop in that regards. So these are large number of neurons, 5,000 to 10,000. But even if 10 to 15% reach the arcuate nucleus, they are sufficient. So there is a redundancy of these neurons. What it means is that when we talk about hypogonadotropic hypogonadism, we say, okay, there is one which is permanent HH and one which is constitutional delay of puberty and growth. So it's not that they are just absolutely opposite things. They may be in between things also. We have seen many CDGP who ultimately developed hypogonadotropic hypogonadism. And many, especially in boys whom we had said, okay, this is permanent, they have a spontaneous puberty. So it means that how many neurons are reaching will decide. So if you need 10% and you have got 20%, you may develop CDGP, but later on you may develop normally. But if you have 15%, you may initially behave like a permanent, but then you may have a response. So there's a variation which happens, which becomes important. Now, GnRH is basically like any other peptide. It's like your pre-pro AVP, it's like pro-opiomelanocortin, like pre-pro PTH. So it's like a pre-pro multiple hormones which come in. From there, you have got the signal peptide, the associated protein, and then you have got a decapeptide. So this is basically a 10 peptide compound. So all these hypothalamic ones are very small. Which is the smallest hormone? Dhwani. Huh? TRH has got 3. Only 3 amino acids. Thyroxine also you can talk, if you talk about that sense, but if you talk about hypothalamic, TRH has got only 3. Once this has got 10, AVP has got 9. It has got some nonapeptide. So now this GnRH is a 10 amino acid one which is released, and its level in the blood will be very, very transient because you will have peptidases. So again, measuring AVP, measuring GnRH or POMC in the blood is not going to help. It's not going to work in the blood at all. GAP has got a much bigger. Sometimes people have talked about whether you can measure that like C-peptide, like the copeptin, whether you can measure that as a surrogate marker, but it's not really required in this setting. There is also a second type of GnRH, which is from a distinct gene, which doesn't really have much role as far as the overall reproductive function, but more with bonding perspective. Now, what does the GnRH do? So GnRH is a gonadotropin releasing hormone. So it's a very simple name. It causes release of gonadotropins. It causes release of both LH and FSH, but it's not that simple. You have got single hormone which is regulating 2 different hormones, LH and FSH. So at a given time, your GnRH is going high or low. Why is that your LH and FSH don't have a same level? Why are they different?
Their regulation is usually controlled by the frequency of the GnRH secretion. If it's a slower one, then the FSH will be the predominant, but pulsatility, if it increases in the prepivotal stages, there will be increased LH secretion.
Yes, so very good point. So 2 points. Because the half-life, we'll talk about how LH, FSH and HCG have a different half-life. If you have one stimulation, one stays for 2 days, one stays for 8 days, of course, one which has longer half-life will have a higher level. Second, the pulsatility also determines which hormone predominates. So pulsatile secretion will cause hormones to go up. But if you give too much of these hormones, it will cause suppression. And this is how we treat for precocious puberty. So, Dr. Fauziya, what is the treatment for precocious puberty, central precocious puberty? Which drug do we use? We use GnRH analogs. But isn't it? We are giving GnRH analog which will stimulate production. So why are we using it in precocious puberty then? Yes. Yes. So if we give at a high dose, it will cause suppression. If you give it like a pump, it will cause progression. Otherwise, it will cause suppression. So long-acting GnRH analog will cause suppression. This is the mechanism for that phenomena which becomes important. So typically, every 1 to 1.5 hours, you will have a peak which will happen. If your pulsatile secretion is less, you will develop functional amenorrhea. So in functional status, your functional status goes towards a lower level, FSH predominant response and amenorrhea. If it's very high level, you will have desensitization, which will happen. Now, lower level of pulses prefers FSH. Higher number of pulses prefer the secretion of LH. Estrogen increases the number of pulses. So when you talk about this whole positive feedback, when your estrogen level goes up, above a level, your pulses will become more LH will come. More estrogen will come, more LH. And then you will have the ovulation, which will suddenly happen. While progesterone, once you have got the luteal phase, will suppress. So your LH will come down, and then your FSH will also slightly going to be more higher in that regards. So GnRH regulation can be inhibitory. So you always know that GABA and these neurons are very important for suppressing puberty. endorphin, CRH, they will all be controlling that. Now, what are the conditions in which your endorphin and CRF levels will be high?
Stressful conditions. Yeah, in stress, like
So if you are in stress, you will have more CRF, you got more pro-opiomelanocortin, more cortisol, more production of endorphin. So often when you talk about girls who go to a boarding place or they go for some exam, they will develop amenorrhea. So this is basically because of the stress, how stress can impact their GnRH and the whole process can be knocked off. So stress has an impact there. Then of course there are pathways like MKRN, which we talked about in terms of the overall precocious puberty basically, and sleep also has an impact. Now, if you are hungry, the body will have less distension of the stomach, ghrelin level will go up. So when you are hungry, would you like to have a pubertal development? No. So ghrelin will suppress. It will say, okay, first let's feed me and then you go for puberty. So then ghrelin will decrease that. There is a gonadotropin inhibitory hormone which has got a minor role to play. Now, there are some stimulatory factors as well, which include norepinephrine, neurokinin B. I'll talk about how KNDY neuron will play a role here. And very important is the kisspeptin. So we have always been talking, okay, GnRH is the king, it's the master, it's regulating everybody. But now we know that GnRH is not expressed in the circumventricular region. So how does it know what is happening in the blood? How does it know that you've got enough nutrition? How does it know that your estrogen level in the blood is high? So for that, there is a messenger. I would not put kisspeptin as a very, very master regulator. It's more like a communicator. It is in the circumventricular region and it tells GnRH, okay, now your leptin levels are high. You can go into puberty. Estrogen is very high. Do not produce too much because we don't want more production from there. So adipocytes, when you got too much fat, you will have leptin, which will act on the leptin receptor, which is there in the kisspeptin neuron to cause, okay, you can now go into puberty. And we'll talk about that a bit later. Now, this KNDY neuron, which is basically a neuron which secretes kisspeptin, neurokinin, and dynorphin. These are the three ones. The most important, of course, is kisspeptin. It is again in the same region, arcuate and the anterior-ventral, posterior-ventral AVPV nuclei of the hypothalamus. It is outside the blood-brain barrier. So it is like you are putting somebody in the border to see, okay, you patrol in that area. If any enemies are coming from that region, you keep an eye on that. So it's like a remote sensing which is happening. And from there, you've got multiple neurotransmitters. Kisspeptin is very, very important. Neurokinin B and dynorphin. So that's why you've got the KNDY. That's what the name comes from, the KNDY neuron. And it also signals the estrogen levels. And we talked about leptin also in the last scenario, as well as the effect of DHT also is regulated from that regards. Now, once your kisspeptin levels are high, especially when your leptin levels are also high, your kisspeptin level will then say the GnRH neuron, okay, this is the right time. Now you should produce your GnRH, and that is how your puberty will start. The first change of puberty which can be diagnosed on a hormonal assessment is LH levels, but anything before that? The pulses. The GnRH pulses or the LH pulses at what time? Night time. So the first change is nighttime pulses, then 24-hour pulses, which becomes important. So now neurokinin B acts via the TAC3 receptor and stimulates this process, and dynorphin also has an inhibitory effect. So if you have now, let's say, a problem in the leptin receptor, kisspeptin 1 receptor, or neurokinin B or TAC3 receptor, you will have what is known as functional GnRH deficiency. I'm not talking about systemic illness causing that. I'm talking about your structure is normal, neurons are there, but they are not functioning. So what finding will exclude that you will have a KIS1 defect, a leptin defect, or a TAC defect? Anything else? One point on history which will say, okay, these are all genetic, so they will be family, they're all autosomal recessive. So what I'm trying to say is that this point on history is there. So this cannot be a kisspeptin defect. Anosmia. So this is beyond that part. So those genes are different, these genes are different. So when you classify, earlier people used to say normoosmic hypogonadotropic hypogonadism and anosmic hypogonadotropic hypogonadism. So this is something to keep an eye from that perspective, and neurokinin B will also have an autoregulatory effect on that. So kisspeptin and overall the KNDY neurons are the most important regulators of GnRH, so to speak, from that perspective. Now, why do boys have a later onset of puberty? Dhwani, why do you think boys have a later onset of puberty? So, okay, what else? Second, of course, is their testosterone is high. So testosterone is suppressing also. And kisspeptin levels are higher in girls. So if your kisspeptin levels are higher, you will have earlier pubertal onset, which is a known phenomenon. So now if you look at GnRH neuron, it is regulated via both neural as well as connective tissue factors. So you have got the KNDY neuron and the local mesenchymal environment which will control it. The KNDY, you've got the neurokinin B, the KIS1 pathway, and then of course you've got the other. So these are all the stimulatory pathways, but you've got a major inhibitory pathway because the brain doesn't want a child to enter puberty. This I discussed earlier, that as soon as somebody is born, there is a mini puberty which happens. And then the brain consciously stops puberty from happening, which does not happen with most animals who immediately develop puberty and they become fertile. Because the human child will require much more time to develop, much more time to learn, or it gives human child more time to learn, so to speak, so that they don't have a burden of fertility till the time of puberty happens. So this is a very important break which evolution has given to the human child so that they don't become reproductively active for around 10, 15, 20 years. And that time their brain will mature, they will have more things to do, that sort of a concept which is there. So this glutamate is a stimulatory one, but the GABA one is what is inhibiting this whole process. So glutamate becomes a stimulatory process in that regards. GABA is opposing this. So it's again a fight. So always the body has made a mechanism that there are two different groups which are acting against each other. So GABA is saying don't go into puberty. Glutamate is saying okay, go into puberty. And this is causing a disruption, and GABA is also inhibiting the KNDY and the other pathway. So GABA is the major regulator of pubertal onset in the beginning. As age matures, other signals come in. The central inhibitory factors say, okay, now this is time that you may go into puberty. Then you have other factors which will come into the picture. Plus, there are local paracrine factors like IGF, FGF, and TGF, which also play a role, which are not very relevant from a endocrine perspective, but they are very relevant from a local perspective in that regards. So in scenarios, when the body says you are matured, GABA will go down, glutamate will go up, and kisspeptin will come up. And then you will have pubertal onset. Now, if you have everything ready, your GABA is gone, your glutamate is high, kisspeptin is there, but you do not have nutrition, will you enter puberty? Why?
Cause the kisspeptin and everything to.
So leptin will not allow kisspeptin to be produced. So you are ready, but your nutrition is not there. So leptin will say stop. So leptin is like a toll gate. So you understand? So suppose you don't have any petrol in your vehicle. Toll gate is open. Will you go out? Yes. You don't have any petrol in your vehicle. Will your vehicle go? It will stay there. So if your glutamate is not there, GABA is high, kisspeptin is sleeping, then even if your leptin is high, your toll gate is open, you won't go out. But if your everything is ready and toll gate is down, you can also not go out. But if you have got enough fuel and toll gate is open, then you can move forward. So the role of leptin is permissive. It will allow or not allow, but it will not cause puberty. Many people say, okay, obesity, leptin is high, that's why they have early puberty. No, they don't have early puberty because of that. There are other mechanisms which are there. Leptin cannot induce puberty. It can only allow puberty when everything is ready. So in a way, leptin is an inhibitor of puberty. More importantly, leptin deficiency is an inhibitor of puberty rather than the other way around. So the main role of leptin is like a symbol that, okay, now you can go into puberty. That is something which is important. And then the local pathway will work from that. So just to summarize the pubertal onset, your GABA is going to really inhibit everything, the KISS, the KNDY, the glutamate, and GnRH is sleeping. Now, once GABA process is disrupted, your KISS peptide starts emerging and you have enough leptin. KISS peptide will start acting on the KISS1 receptor. It will cause GnRH neurons to stimulate. GnRH comes out and you have a pubertal onset. Now, GnRH, I said, is a decapeptyl and it's a peptide, so it will have a very, very short half-life. It will be few minutes. You can't use it as a therapeutic agent. So that's why there have been structural modifications in the form of GnRH analogs to allow a longer duration of action. So you've got leuprolide, which is the most common GnRH analog which we use. You have got this D-leuprolide instead of the glycine, which is there, again a decapeptyl. Triptorelin, again, you've got a triptorelin which is there, and there is also a histrelin, which is a once-a-year implant, which is not routinely available here, but in USA. So structural modifications have allowed a longer duration of action of these agents. There's also a GnRH antagonist, which is there, but it is not used for treatment of precocious puberty. So where all can you think your GnRH can be used? Both agonist, antagonist, which all could be the indications?
For precocious puberty.
Yes. So hypogonadotropic hypogonadism because of, let's say, Kallmann syndrome, but there you need a pulsatile GnRH. So there are studies about the pump. They use pump to give every 60 minutes a pulse is given. So this is one area. Delayed puberty for fertility induction, it will be very good because that's the ideal scenario. Where else? So antagonist, where is it used? In IVF. So they want a controlled, they don't want the GnRH surge to happen. So they're giving other medications, they stop it using the antagonist. And once you give antagonist and stop it, suddenly the GnRH will boom out. It will be a reversible phenomena where it will be used from that regards. So GnRH is basically acting via this G protein receptor.